I think most of you must be aware that this is the second most common site for osteoarticular tuberculosis after the spine. The interesting thing is there's often a delay in diagnosis, which then leads to significant joint destruction and significant disability. And the earlier options were not entirely satisfactory, as has been discussed in some of the talks earlier. I think today, if you get the patient in the early stage, you would consider rest and maybe traction and give them appropriate chemotherapy, but ideally this should be after tissue diagnosis and not empirical. And then you would start supervised joint mobilization, and if the initial response was not adequate, you would consider surgical debridement of the joint, synovectomy, wash it out, take tissue for biopsy, as well as tuberculous culture and sensitivity, and then maybe put them on skeletal traction for a period so that you can maintain some mobility in the joint. So what about further treatment? I think if you manage to get good control of the infection with satisfactory function of the joint, you would continue with the medical treatment and add physical therapy, and that hopefully would be all that is required, but often the end result is not satisfactory, and then you have to think of various options. And the earlier options were girdle stone arthroplasty, which did reasonably well in a lot of patients, but certainly there was shortening, there was limp, although they were able to do a lot of their functions of daily living, and arthrodesis, which had its subsequent problems of back pain, etc. So total hip replacement is probably the most appropriate solution for end-stage arthritis after tuberculosis hip. So there's no doubt that the best functional results that you'll get after TB arthritis is with a total hip replacement, and it gives you the best in terms of mobility as well as stability of the hip. So I think today that would be the best option that is available for us where it is practically possible. So here's an example. This was a 45-year-old lady who had had tuberculosis of her hip about 4 years earlier. She had healed disease but had significant limp and pain in the left hip, and we did a hybrid total hip replacement with an uncemented cup and a cemented stem, highly polished stem, and this is her at 7 years post-op, her x-ray at 7 years, and she's doing really well without any problems even further down the line. So it's around 12 years now, she's still going on satisfactorily. There are, however, areas of controversy, and this includes the timing of surgery, how long do you give pre-op and post-op chemotherapy, the type of prosthesis, whether cementless is better or cemented is better, whether you should be doing it in 1 stage or 2 stage, and if in 2 stages, the duration of interval and composition of antibiotics you would put into a cement spacer, and of course if there's reactivation, can you retain the implants or you would need to remove the prosthesis. So we touch on these points bit by bit. I think as I mentioned earlier, total hip replacement, once the disease is healed, if there is significant problems with either arthritis or the sequelae of tuberculosis hip, I think there's not much argument as to what would be the best option in terms of treatment in most patients. However, if we actually wait for the disease to be completely quiescent, it's really quite variable, and various studies have showed that it may take as long as 10 to 20 years for the disease to be completely quiescent, and it's not practical to really wait for that long. So if you look at some of the earlier studies, this why Babulkar et al. Said that you should wait at least 10 years, Netwall et al. At least 7 years, and Ronald said, yes, waiting for a long time is not a bad idea. But as mentioned earlier, it is, if patients have significant disability, it would be really difficult to keep them going for 10 years after the arthritis has set in. So more recently, a number of papers have suggested that total hip replacement can be done successfully even in the active phase of the disease, and here the more recent papers all suggest that successful total hip replacement can be done in the active phase of the disease. The rationale of doing it in the active stage is that the tuberculous bacteria, unlike staph, etc., is a slow-growing bacteria. It does not adhere to metal. It does not form a biofilm as the other bacteria do, and the use of implants in spinal tuberculosis, even in active disease, has been fairly well established. What about pre and post-op chemotherapy? Again, the study by Berberi et al. Showed that there was a lesser rate of reactivation of infection in those who had received ATT prophylaxis as compared to those who had not. So there's some rationale in giving preoperative chemoprophylaxis. How long? I think this varies again, and in various papers you can have anything between 2 weeks to 3 months of pre-op chemotherapy, even in the heel disease, before doing the total hip replacement, but probably about 3 to 4 weeks is in a heel disease is where the consensus would be arriving. So here, Sidhu et al. Did it after 3 months. Kim et al. Gave post-operative chemotherapy. In this sort of review article, meta-analysis found that the duration of post-operative chemotherapy was anything between 6 to 15 months. What about cemented or cementless? I think there really is no conclusive data to show which is better. Kim et al. Suggested that since the patients were relatively young, therefore cementless would be better. Kumar et al. Showed no failure osteolysis in cementless implants at an average follow-up of 8.3 years, but there have been similarly satisfactory results with cementless hip, and so there's no real clear advantage of cemented versus cementless in these patients. And a number of studies looking at THR in active tuberculosis hip with successful outcomes, and this is from a meta-analysis paper from Mani et al. Published recently, 2017, so which looks at various papers and the meta-analysis. So here's a patient who we were not clear what the diagnosis was. When we went in, she still had active disease, which turned out to be tuberculosis on the biopsy, but we felt that we could go ahead, do a thorough debridement and a total hip replacement, and she did well. This is her at about a year later, doing quite well without any problems with subsequent chemotherapy for tuberculosis for 12 months. Again, studies looking at total hip replacement with after heel disease, again showing satisfactory results. But if you notice in this paper by Kumar, even though it was done for healed disease, they had 2 patients who had reactivation of the disease. So just because you wait is not a guarantee that you will not get reactivation of the disease. Where would you think of a 2-stage total hip and not go to a single-stage total hip? I think certainly patients with multiple sinuses, it would be sort of probably better to do it in 2 stages, do a thorough debridement, and then go ahead. Also in patients with sort of not very good general health and high risk of reactivation. So these papers, Nyogi et al., Shen et al., looked at doing 2-stage revision, especially in the presence of sinuses or patients with high risk of reactivation. And some of the factors which would have a high risk of reactivation include patients on steroids, malnutrition, diseases such as HIV or AIDS, smokers or substance abuse, silicosis, chronic renal failure, etc. And you also have other patients who may not be compliant with the antituberculous treatment or with chronic discharging sinuses, which may not be good candidates for total hip replacement. So this patient who we had a girdle stone arthroplasty earlier for tuberculosis, but when we went in, she had sort of active disease, so we decided for a 2-stage, did a thorough debridement, cement implantation, and then revision a hip later after about 2 months. When you get reactivation, can you sort of retain the implants or not? These 2 studies suggested that you should remove the prosthesis to control reactivation, but these 2 studies by McCulloch et al. And Kumar et al. Suggested that you could just continue with the prosthesis, give them chemotherapy, and hopefully that would be the end of the disease, or you'd be able to control the disease. So where do we stand today? I think it's important to establish histopathological diagnosis wherever possible. Total hip has a definite role in end-stage disease, and the consensus of opinion is moving towards THR even in the active disease where it's necessary. And I think today there is more and more support for THR in active disease. However, accurate diagnosis, efficient pre-op and post-op ATT are critical to this. There's no difference in the reactivation or healing with cemented or cementless implants, and hips with discharging sinuses are probably not good candidates for a one-stage total hip replacement. Thank you.